Chin Tan Min. I'll just do a short introduction of Dr. Chin. Dr. Chin is a senior consultant medical oncologist with us. Her area of expertise and interest is in lung cancer, in addition to general oncology. Dr. Chin graduated from the National University of Singapore and completed her internal medicine and oncology training at the National University Hospital. She was awarded the Singapore Government Health Manpower Development Program Fellowship to pursue further subspecialization training in thoracic oncology with a clinical and research fellowship at the Massachusetts General Hospital Cancer Center in USA. Prior to joining private practice, Dr. Chin was practicing as a senior consultant at the National University Cancer Institute at NUH and also a visiting consultant at the Ng Teng Fong Hospital until 2017. Dr. Chin's commitment to patient care has been recognized by Spring's Excellence Service Award. In addition, Dr. Chin contributes her expertise to thoracic oncology in various Ministry of Health committees, formulating guidelines on screening and treatment for lung cancer, my apologies. Dr. Chin is an advisory member for lung cancer for Singapore Cancer Society and has been involved in many educational talks for the public. So the second speaker today we have with us will be Dr. Lee Yushan. Dr. Lee is a senior consultant hematologist. His area of expertise is in hematology such as lymphoma, myeloma, and hematopoietic stem cell transplant. Dr. Lee received his basic medical degree from the University of Malaya in 2003 and membership of the Royal College of Physicians in 2007. He completed his hematology training at the Singapore General Hospital and subsequently obtained his fellowship of the Royal College of Pathologists from the United Kingdom in 2013. Dr. Lee has worked for 10 years in SGH and received Gold and Star Awards under the Singapore Health Quality Service Awards. He was formerly the Director of Lymphoma Service in Department of Hematology in SGH and also the Lymphoma Lead in SingHealth Duke Blood Cancer Center. Dr. Lee is active in collaborative work locally under the SDVCC and Singapore Lymphoma Working Group, as well as regionally for chronic lymphocytic leukemia. He is currently a member of SingHealth Institutional Review Board and sat on several pharmaceutical advisory boards. So I've managed to share with you the background of our doctors. Without further ado, I'll pass on the session to Dr. Chin to start her presentation. Dr. Chin, please.
Hello, everybody. A very good morning, and thank you very much for joining us this morning. I will be speaking about lung cancer today, and I'm going to proceed to share my screen and some of the slides that I've prepared. Okay, so this morning we are speaking about advances in treatment for lung cancer. This is not so much of a comprehensive talk, but more tailored to answer the questions that some of you have sent in prior to the talk. And to start the session, I thought we would address some of the common perceptions that patients and the public may have about cancer. Usually when we tell a patient that they have cancer, the reaction is one of distraught, fear. There's a lot of concern. Concern if they can be treated, about the efficacy of treatment, and if they were to receive treatment, the chance of survival, as well as the side effects that come with treatment. So before I go on to share a little bit more about the advances and how we can support patients through the treatment, I thought it would be a good idea to have everybody here participate in a polling question so that we know what worries you most. So we have 1 minute for everyone to vote. What is it that worries you most? Is it the cancer diagnosis? Is it side effects arising from treatment? Are you worried about whether the treatment that you are undertaking is going to work? Or is the chance of survival a major concern? So I'm going to encourage everybody to vote. You have 1 minute to do so. So for those of you who have voted, we will come back to the same polling question subsequently halfway through the talk after we have covered some questions. Okay, so 60% of you are concerned about the chance of survival, and the rest are kind of equally split between the concern of cancer diagnosis, treatment side effects, as well as whether the treatment that you're going to get would work. Okay, I think that is very fair, and actually to address your concerns, we will start the ball rolling. I've got some questions which have been sent in, and I'm going to address them one by one. Okay, so, I think a lot of us, as we have seen in the polling question, are concerned about the success rate for the treatment of lung cancer. And I think this is a very fair question. So when we first see a patient, this is usually the first question that they would ask. What is the success rate for treatment of cancer? I would say that in general, the earlier the stage at diagnosis of cancer, the better the chance of survival and cure. And so usually we encourage that if patients feel that they are not well, to seek medical treatment a little bit earlier, because that really improves the chance of a cure for cancer. And as you can see from the slide here, I have put up in a red box, the earlier the stage of diagnosis of cancer, the better the chance of survival. Now, for lung cancer specifically, if you follow the figures here, you can see that the 5-year survival for patients who are diagnosed with stage 1 cancer is pretty good. We're looking at about 80 to 90% of all patients being alive and well at 5 years. Conversely, if you look at patients who are diagnosed with stage 4 cancers, meaning that the cancer has gone beyond the lung, it's affected other parts of the body, including the liver, the bone, the brain, then we would say that the prognosis and the chance of cure is not so good in these patients. Traditionally, the prognosis is relatively grim. We are looking at a projected rate of about 5 to 10% chance of all stage 4 lung cancer patients being alive at 5 years. So the take home from this slide is that we encourage all patients to seek medical care early, because the earlier stage of diagnosis makes a difference in terms of the cure rate. Now, this slide is taken from the Singapore Cancer Registry, which shows us the number of deaths arising from cancer, and this is specific for lung cancer. You can see that over the years, the number of deaths from lung cancer has come down. I think this is in part due to increased awareness from the public. People and patients are coming forward when they are diagnosed with earlier stage of cancer, and therefore the cure rate has improved. The other part probably is due to improved treatment options that we have for patients these days. So we spoke about how stage 4 patients have a relatively grim prognosis of about 5 to 10% at 5 years. And we will now go through how much improvement we have these days compared to 20 years ago for a stage 4 lung cancer patient. So if you focus on the graph on the left-hand corner, with chemotherapy in 2002, we say to patients with stage 4 lung cancer patients that with treatment, with chemotherapy, we can buy you time. The average median survival is around about 8 months in these cases, and you can see that the 5-year survival is less than 5%. Now that's with the traditional chemotherapy, but over the past 5 to 10 years, I would say that the treatment landscape for lung cancer has changed completely. We have a lot more treatment options, and one of them is immunotherapy. So you may have heard from the news that immunotherapy works very well for cancer patients. And indeed, we find that in lung cancer patients, if everyone gets immunotherapy, there may be about 20% of this cohort of patients who may still be alive and well at 5 years. And this is a marked improvement over the 5% that we use to quote patients with just traditional chemotherapy alone. The other big treatment option and development over the past 20 years or so is the availability of targeted medication. And as you can see from the graph, again, 50% of patients survive at the 3 and the 4-year mark. So if we then tabulate numbers, in 2002, the 5-year survival is less than 5% for a patient with stage 4 lung cancer, but in 2020, things are extremely different. Now, for a patient who is suited for targeted treatment, I would say that the average survival for someone who is on the appropriate treatment and who responds to the treatment has got a good chance of survival, and the average is probably about 2 to 3 years, if not more. And we are also beginning to see that with immunotherapy, a proportion of patients can respond very well, and they have got good sustained control with minimal disease in the long term. Okay, so these numbers set the stage for the next section of the talk, which is the novel developments and what we can offer patients these days. But before I talk about the newer developments, I thought it's very important also to appreciate and understand that the major cornerstones of cancer are still very relevant in today. Okay, now we'll go through them one by one. The first is surgery. Surgery involves the physical taking out of a cancer if we do find that it is localized. There are different types of surgeries that can be performed. Now, if a tumor is very small, then the surgeon may be able to do a smaller operation. They take out part of the lung. Sometimes they take out part of the lobe. Or if the cancer is more advanced and it's involved more parts of the lung, then perhaps they may have to take out the whole lung, which is what we call a pneumonectomy. Now, these days, the surgical techniques are pretty advanced, and more surgeons are able to do less invasive operations, such as keyhole surgeries, and recovery is pretty fast. So I would say that surgery offers a very good local option for patients who present with early stage cancers, and we're aiming for cure in these cases. The next big cornerstone of cancer treatment is radiotherapy or radiation treatment. Here you see the machine that's used for radiation treatment. It is very similar to a CT scan machine. And essentially, we use high-dose X-rays. We target the area of tumor that requires treatment, and we try to kill the tumor with high-dose X-ray. Again, like surgery, radiation is more suited for patients with localized tumor. It can also result in very good control for patients who have problems arising from invasion of the tumor into the bones, for example, presenting with pain or presenting with hemoptysis, like blood in the sputum. The next big treatment option, which we've had for many years, is chemotherapy. Most of you probably would have heard and would be familiar with chemotherapy. This is usually an injection medication that is given via an intravenous plug. And it works by killing rapidly dividing cells. And because cancer rapidly divides, chemotherapy generally works to kill the tumor. But unfortunately, this also explains for some of the common side effects that we see from chemotherapy. Because the hair follicles and the bone marrow are also rapidly dividing. Therefore, these tend to be more affected by chemotherapy, accounting for some of the common side effects that patients may have. And this includes hair loss, increased predisposition to infections. But I'm very happy to say that, I think through the years, the supportive care for side effects for chemotherapy has improved markedly. And most patients actually go through chemotherapy without too many problems. And in fact, some of them are well enough to go back to work. So we spoke about surgery, radiation, chemotherapy, the main cornerstones, which are still very relevant in today's cancer care. But I will move on to the more novel treatment options that we've had over the past 10 to 15 years to talk about the advances. So in addition to chemotherapy being the mainstay, from 2004, we started using targeted treatment for lung cancer. Now, the basis for that is that we discovered that there are certain lung cancers which are driven by very specific mutations in the tumor. And if you can find the mutation and you block it with a medication that can block the activity of the mutation, then this results in a very good response and tumor shrinkage. So this cartoon shows the background. It looks like a busy slide, but if you can imagine that we spoke about the marker that's driving the tumor. So this is a receptor that we find on cancer cells. And in lung cancers, effectively this switch is always on. And we call it a cancer which is addicted. So it's always on. And what it does is it drives the downstream signals and the cancer keeps growing. And with the medication, with targeted treatment, it essentially flips the on switch to off, therefore shutting down the growth signals and the tumor shrinks. So this is an example of what targeted treatment can do. This is a patient who presented with cough, with blood in the sputum. He had a lot of left-sided chest pain because of the tumor that you can see here. The lymph nodes were also affected. And after 2 months of targeted treatment, we can see that the tumor is markedly smaller and his symptoms of cough, pain are also much, much better. So targeted treatment can be very effective if we're able to find the mutation to target. So the treatment paradigm for lung cancer these days would be that if we suspect someone may have a diagnosis of lung cancer, for example, this patient presented again with cough, shortness of breath, and you can see that there are multiple white spots in both lungs. This patient again presented with water in the lungs, and upon confirmation of the diagnosis of cancer and profiling the cancer, we know that this patient had ALK fusion and this patient had an EGFR mutation, and we treated respectively with the medications that could target these genes. And these patients responded very promptly and very well with efficient improvement of their symptoms. So when we first started in the early 2000s, these were the genes that we had looked for. We looked for EGFR, we looked for ALK, and as the years went by and technology became more advanced and sophisticated, we were able to find more and more genes that were driving lung cancers. So you can see on the right side of the panel that we now have many, many genes to look for. And on the parallel, if we find these genes, the good news is that we are able to have medications to target these respective genes. And very often patients feel much better in a very short time with relatively sustained control of the cancer. So we have seen that patients respond on scans, the tumor masses shrink, and very importantly, I think one of the key endpoints to treatment of cancer is that patients must feel better. So the symptoms arising from the cancer must improve. And like I've alluded to previously, patients usually have very prompt improvement. They say, hey, doctor, my cough is much better. I feel that I can do more. My appetite has improved. I'm now hungry and my weight has started to stabilize. And in fact, I'm putting on weight. So these really are the parameters that we would like to achieve for someone who starts on cancer treatment. The other important endpoint that we would also like to see is that we want to buy patients more time and hopefully a sustained duration of meaningful quality of life with cancer treatment. And indeed, if we go back to the historic figures of an average survival of about 6 to 8 months for a stage 4 patient, now you see that with targeted treatment, with efficient control of the tumor, we are actually buying patients a lot more time. 50% of patients survive at 3 years if you have the EGFR mutation and if we treat you with a specific medication. And outpatients, 50% of them are surviving at the 4-year mark. So this is a remarkable improvement, and it really is a leap and offers a lot more for treatment for patients with advanced lung cancer diagnosis. Okay, so we spoke about targeted treatment, and I will move on to the next big group of treatment, which is immunotherapy. So we said in a patient with lung cancer, we try to look for a target, and if the target is present, that we will treat it with targeted treatment. In someone who unfortunately does not have a target that we can target, there is always chemotherapy that we can use. And over the past 5 years or so, we have also found that immunotherapy can work very well for specific subgroups of lung cancer patients. And how does it work? So in a healthy individual, the immune system is very important. It acts like the police. It goes around surveying for foreign cells, such as viruses, bugs, bacteria, and cancer cells, essentially things which should not be in a healthy body. And in cancer, somehow the immune system is unable to recognize the presence of tumor, and therefore the tumor is able to grow, proliferate, and cause problems. And we think that cancer does this perhaps because they have developed a shield which makes them not so visible to the patient's own immune system. And what immunotherapy does is it makes the cancer cells more visible. And therefore, the immune system is able to do its job, which is that ordinarily in a cancer patient, the immune system is akin to being stopped at the red light. But immunotherapy somehow is able to make the immune system recognize that there are foreign cells, there is cancer, and therefore the immune system now unleashes and does what it's supposed to do, and it gets rid of the foreign cells, which is the cancer, and therefore results in cancer control. This is a patient who again presented with the typical symptoms of cough, and you can see here on the PET scan that clearly there is a mass which is not normal, and this is an active cancer. As you can see, it is lighting up on the PET scan. And because she was expressing PD-L1, which was a marker for potential response to immunotherapy, we chose to give this lady immunotherapy as first-line treatment without chemotherapy, without targeted treatment. And as you can see that 2 months after immunotherapy, the mass has shrunk, and at 4 months, it is insignificant with very little activity of cancer. So this shows that immunotherapy can be active on its own for someone who potentially can respond with a high PD-L1 expression. So that's a lady with non-small cell lung cancer. And this is a man who has another subtype of lung cancer, small cell lung cancer, which is more commonly seen in smokers. He presented with a lung mass. His mediastinal lymph nodes were affected, and also he had multiple spots in the liver. So this man has advanced cancer, and we needed something to treat all the cancer spots in the body. So I gave him a combination of immunotherapy and chemotherapy, and 2 months after the treatment, you can see that what was originally a big, very active lung mass, lymph nodes, and spots in the liver have all resolved largely. So clearly, this treatment has worked for this patient, and we are beginning to see more and more examples of how effective immunotherapy can be for lung cancer. So from 2015, we have started to use immunotherapy in addition to targeted treatment and chemotherapy for stage 4 lung cancer patients. And we are also beginning to find out a little bit more about immunotherapy. Like I said, there are some patients who can respond quite well. And when they do respond well, the duration of control can be quite sustained. And there are certain biomarkers which allows us to pick out patients who potentially may respond better than someone who may not. So this graph shows that for patients who express the biomarker similar to a mutation in the cancer cell, we call it PDL1. If you have a higher PDL1 expression, you may respond better than someone who does not have such a high PDL1 expression. And certainly, we see that there's a proportion of patients here who are well at 5 years. Again, I bring your attention to the fact that this is an improvement over the historic numbers that we used to quote for patients. The other thing that we are also beginning to learn is that immunotherapy is generally very well tolerated. I think 80 to 90% of all patients who get immunotherapy actually have sailed through it, and they come in and they say, oh, I'm feeling very well, and there are none of the side effects that you have counseled me about. So, but what immunotherapy can do is that it results in a very hyperactive immune system, and sometimes the body ends up attacking the patient's own organs. And the organs that can be affected could be the lungs, it can be the liver, it can be the colon. And so usually we tell patients that if you run into any of these problems, the key is early recognition so that we can stop the immunotherapy and treat the symptoms accordingly. So the indications of immunotherapy in lung cancer, just to summarize, for someone with advanced disease, in the absence of mutations that we can target, meaning no targeted treatment, we can use it first line, either as a single agent, and you have seen that it works pretty well, or in combination with chemotherapy. And for patients who have not used immunotherapy prior, we can again use it in second, third line after chemotherapy or targeted treatment. In patients with localized disease with lung mass, involvement of the lymph nodes in stage 3 disease, we find that immunotherapy also works quite well following chemo-RT. And this is a list of the potential immunotherapy that you may read about or your doctor may have discussed with you. I think they are all generally quite effective and work the same way. So I have come to the end of the treatment section. We will move on to address other questions, but I thought it would be good at this point, again, to revisit what we had said before. So now that we have covered some bits about treatment options and how effective it is, does it change your worry and concern? So we have 1 minute. Okay, so that's good. So in the first poll, we had about 60% who said that they were concerned about their chance of survival. Now that's dropped to almost half of what it was before. But it's interesting also that some have spoken about their concern of efficacy of treatment. Okay, all right. I think we will address some of those maybe later on in the Q&A session, but we will move on to the next part of the talk. So we spoke about how treatment can be very effective for advanced stage lung cancers. And I think the other important thing is for someone who has received curative intent surgery for early stage cancers, the common question and concern is the lung cancer going to come back? And is there anything that we can do to prevent recurrence of lung
Halo,
cancer?
terima kasih. Sudah salah tri.
So I want to share these slides that were presented at ASCO this year. So ASCO is a big cancer meeting that is held every year, and there are lots of exciting developments and new treatment options for patients that are usually presented at this major conference. And one of the key studies looked at whether targeted treatment would be suited for patients who have received surgery. And the background is that if you look at this slide, there are two take-home messages. For patients with apparently early stage lung cancers, stage 1, stage 2, stage 3, if you look at the 5-year survival, 50% of all of these patients would eventually recur with some form of recurrence, either locally in the lungs or in more distant areas such as the liver, the bones. And so the key to reducing recurrence is that usually after surgery, we would try to clean up with either chemotherapy or in some cases, in addition to chemotherapy with radiation treatment in order to cut down on the chance of recurrence for lung cancer. Generally, patients with stage 3 lung cancers tend to recur a little bit more. They are at higher risk compared to those with stage 2 and stage 1 diagnosis. And as you can see, as the cancer moves towards a more advanced stage of stage 3 cancer, more patients tend to benefit from adjuvant chemotherapy or radiation after curative surgery. And therefore, international guidelines now do recommend that for patients who had curative intent surgery, and if you have stage 2 and stage 3 lung cancer, meaning that the mediastinal lymph nodes are involved, in addition to the lung, that generally we recommend patients undergo 4 cycles of platinum-based chemotherapy to improve on the chance of long-term cure. Okay, now if you have stage 1B lung cancer, then it really depends on whether there are any high-risk features such as a tumor which is more than 4 centimeters, and usually we discuss with the patient potential benefits and side effects. In stage 1A, there is no recommendation for adjuvant chemotherapy at this point. And so the study that was presented by Dr. Roy Herx and on behalf of the investigators is the ADURA study. And what they did differently from traditional standard of care is that in patients who are known to have mutations, EGFR mutations, they treated them for 3 years with targeted treatment. And you can see here that those who had suppression of the cancer with targeted treatment did a lot better than those who did not. So this is a very exciting study and really opens up the option for the use of targeted treatment in patients who had surgery and who also express EGFR. So rather than giving chemotherapy for some of these patients, it opens up the option of perhaps oral maintenance treatment for 3 years post-surgery. Okay, and I'm going to switch text and talk a little bit about epidemiology and whether there are any associations with smoking. There was a question that came in and it said, is lung cancer caused by smoking? Now the short answer is yes. And you can see from the graph here that there is a very close association between the number of cigarettes. The more you smoke, the higher the risk of developing lung cancer. So definitely, I would say that if you're a smoker, you are more at risk of lung cancer, especially the small cell type, than someone who does not smoke. And on the parallel, you also see that as we are more aware with anti-smoking campaigns, and people are cutting down on their smoking habits and the number of cigars that they are smoking. Indeed, the incidence of lung cancer has come down. The number of lung cancer diagnoses have reduced over the years, and this is very good news. We can actually prevent lung cancer by cutting down on the risk factor of smoking. And I also want to say that for someone who has smoked for a long time and is still smoking, it is not too late to cut down or to stop smoking, because we do find that if you cut down and you eventually do stop, your risk of developing lung cancer then goes back more to someone who does not smoke. So the motivation amongst the smokers here is that try to cut down, and if you can, stop smoking. Okay, the other common worry for patients is side effects. This is a common discussion point for a lot of my patients who come through. They worry if the side effects would bog them down and make them make their quality of life much worse. So I would say that this is also the concern of the oncologist. When we do start treatment, we do not want patients to be bogged down by side effects of treatment. And for sure, we do not want the side effects to outweigh the improvement in symptoms, in cancer-related symptoms. I am happy to say that I think with supportive care for chemotherapy, most patients do relatively well with treatment without too many side effects. And in the event that they do develop side effects, we have very good medications to counteract the side effects. And if that still does not work, then there is always the option of changing medication or reducing the dose such that the treatment is as tolerable as it should be. And in the end, really, what we're trying to achieve is what the patients want. That we want the cancer-related symptoms to improve, and at the same time, not to be overburdened by the side effects of treatment. Okay, now the next question I had was, people say treatment actually causes cancer cells to spread faster. Is that true? So this, I think, is a rather common misperception. And I have to say that the natural biology tendency of cancers is that it will grow without cancer treatment and eventually cause problems. So when we do start patients on treatment, be it chemo, immunotherapy, targeted treatment, we always counsel patients that we have a 70 to 80% chance, for example, with targeted treatment, that the cancer treatment that we have given will work. But unfortunately, cancer is made up of many different types of cells, and sometimes, despite the treatment, there will be some resistant cancer cells that may grow. And therefore, the cancer grows despite the treatment. And if that happens, then the next thing to do would be to move on to some other treatment to hopefully control the more resistant cells. So the thinking here should not be that treatment causes the cancer to grow, but I would say that it's the innate biology of the cancer. Some of it is more resistant to treatment, and therefore the cancer grows despite cancer treatment. Okay, so I think I'm almost nearing the end of my talk, and I would say in summary that lung cancer is common. It is the top second cancer amongst Singaporean men, the third most common in Singaporean women, and is also the top cause of death for cancer in Singapore. And it can affect anybody, women, men, smokers, more than non-smokers, but non-smokers also are sometimes at risk. When we see a patient with a lung mass, we usually confirm the diagnosis with the biopsy. And after confirmation of the diagnosis of cancer, then we profile the tumor. And the reason to profile would be that we want to know what is the most appropriate first-line treatment for the patient, whether it's targeted treatment, immunotherapy plus chemotherapy. And at the same time, not only do we assess the tumor, we assess the patient. We assess what the patient can tolerate, their reserves, and come up with the most appropriate treatment plan that can maximize on tumor response and minimize on side effects for the patient. I thought also to share, two stories which may be inspiring for the patients amongst us. So this is a lady that I first met 8 years ago, and at diagnosis, she had involvement of the brain from lung cancer. She had undergone surgery, and she was also treated with targeted treatment and chemotherapy. And I'm very happy to say that 8 years down the road, she has very minimal disease and is very well. So I think with appropriate treatment, patients can do well despite a very advanced stage of diagnosis initially. And again, this is another patient who had advanced disease at diagnosis. When we first met, he was in a lot of pain from bony involvement from the lung cancer. And because the lungs were affected, he was hardly able to get through a sentence. But we found that he had the ALK fusion, and we treated him with the appropriate medication. And within 2 to 3 months, his symptoms had improved, and now he is right back up to doing what he used to do. Mountain climbing, playing on musical instruments. So this is a testimony of how well patients can do despite being very sick at diagnosis with appropriate medications. And so increasingly, I think I tell my patients that cancer is just one chapter in your life and it's not your whole story. And as you can see, there are patients who have done it, and I'm sure others can as well. Before I end, I just want to say that we have focused primarily on medications and treatment for advanced cancer patients, but there are also many other areas of development. I think the surgeons would tell you that their surgical techniques are far more advanced these days. They can do less invasive surgeries with more specific and sophisticated machines. The radiation therapists are able to target the tumor better and affect less of the surrounding normal tissues. And importantly, the multidisciplinary care from dietitian support, physiotherapy, has all led to improved outcomes for cancer care. So I'm going to end now, and I want to say that I hope after this talk that the cancer diagnosis is not as bad a problem as before. In terms of treatment side effects, we have much improved supportive care, and a lot of patients go through treatment without too many problems. You have seen for yourself that treatment can be very effective. The control can be very sustained, and we are looking at long-term survivors for cancer patients. Okay, and we have spoken about many changes, but there are two things which haven't changed. I always say that I look forward to my patient coming to say that, hey doctor, I'm very glad my life has come back to what it was from before. With treatment, I can now eat, I can exercise, I can do what I like. Simple pleasures of life. And the second thing which hasn't changed is our commitment to fighting cancer. Okay, and great progress has been made over the past 20 years in the treatment of lung cancer. So if I can get everyone to vote again, just to see whether it's changed, you have 1 minute to do so. And also, just to note that we have added one more option to the first 4. So we do not have so much concerns and worries now. So let's see.
Apa? Si itu siapa? Lihat aja ke sini dulu. Kalau main bapak nggak boleh situ, itu jurang. Itu jurang untuk tinggi di kota boneka.
Okay, so I think it was worthwhile the morning. It looks like half of you is not so much concerned about cancer diagnosis and the treatment side effects as well as the efficacy of treatment. I'm very glad to see this. And I think we will end this section of the talk. We can continue our discussion during the Q&A session. And I have to hand the podium now to my colleague, Dr. Lee, who will do the second part of the talk on blood cancers. Hey, Yushan, all yours.
Okay. Hi, a very good afternoon. Thanks for joining our webinar today. And my name is Dr. Lee. I'm the hematologist with the Parkway Cancer Center. So my topic today is about immunotherapy and all this targeted therapy in the blood cancer. So before I start, let's see first. We'll start the talk with the one polling questions. What is blood cancer?
So si Mbak si Jenis legal tuh Mi? Tuh tadi dari suara naon tuh?
This is more like an introduction to see how much. Wow, I guess if that's the answer, my job here will be quite simple. A little bit more only on treatment. So as we all, most of us know that the blood cancer is not a cancer. It comprises of these three major subgroups of cancer, mainly leukemia, lymphoma, and myeloma. So in this talk, it's very difficult to get just a group of medication that will cover all three groups of cancer. Hence, I'll go in each subgroup of cancer and discuss a little bit more where all this new targeted treatment as well as immunotherapy works. With this acute leukemia first. Of course, this is a more well-known, but this is not the only subtype of blood cancer. The reason why it's more well-known is because this is one of the most aggressive type of blood cancer. Usually, patients present with this prolonged fever, high white cell count, and that's how they went to see their general practitioner or their GP. And the patient may have also symptoms of anemia, such as tiredness, lethargy, and they have a reduced effort tolerance, and they may even have giddiness at times. Some patients may also present with signs of bleeding, such as gum bleeding or bruises over the skin. And sometimes they may have this gum swelling. And this acute leukemia needs to be diagnosed quickly, and the treatment should be started soon after you have the diagnosis. Time is very precious when you talk about acute leukemia. So now this gives the general overview of treatment for acute leukemia. Basically, we divide it into three phases: induction, consolidation, plus or minus stem cell transplant, which means not all the patient needs stem cell transplant. The aim of this chemotherapy is to bring the disease into remission. When we talk about remission, classically or historically, we look at the leukemic cell must be less than 5%. However, now we know that the deeper the response is, actually the better the outcome. Hence, that this new thing called measurable residual disease, or we call MRD. If patient can achieve a negative MRD or genetically become normal based on some genetic profile of molecular response, the patient can do better. Now, where does all this new targeted treatment fits in during induction? We can always combine it with chemotherapy during three phases of treatment, such as induction, consolidation, even after post transplant. And below there are a few of these new targeted treatment that we use or immunotherapy that we use, which can be incorporated together with the chemotherapy. And where else can the patient, all this new treatment fits in? When patient fail the treatment, the first line treatment, means we try to aim for a remission which is less than 5%, but patient couldn't reach that. So we will try to rescue the patient with some newer treatment we call salvage treatment, and that's where all the new agent fits well. So when we talk about leukemia, we always divide the leukemia into two major subtypes: acute myeloid leukemia (AML) or acute lymphoblastic leukemia (ALL). And in between, always there's this mixed group we call mixed phenotype or leukemia or MPL. Now we start to talk with the acute myeloid leukemia first. So one of the genetic targets being identified, there are many being identified, but this is one of the most commonly acquired genetic mutation, which is called FLT3. So when patients have this type of FLT3 mutation, what happens is that the cell proliferate more, and this kind of acute leukemia cell have a survival advantage. Hence, the chemotherapy alone may not work that well. Although there are two types of this genetic mutation, ITD and PKD, most of the time it's the ITD, and this is the most important targetable genetic defect in AML. And what is so different? When you incorporate this new treatment, targeted treatment with chemotherapy, you increase the survival by 3-fold. So hence, currently it is the standard. If a patient has this mutation, we always incorporate this new targeted treatment with the chemotherapy. Shown here is one of the patient of mine that presented with this AML and FLT3. He actually presented with fever, a bit of mild cough, and gum swelling. Went to see a GP initially and treated as a upper respiratory infection, but the fever never resolved, and hence he came and presented to the A&E. When you look at when you see a hematologist, we always look at the white cell count, and you can see that the white cell count is raised at 32,000. And we also noted that this monocyte. So for hematologists, we always look at this weird cell called hematology. It's not weird; it's part of the normal immune system. But when it is too high, we always worry that this patient may have certain type of either typical infection or leukemia. And then you can see that we always look at this thing called blast cell. Blast cell. This basically means these are the leukemic cells, and it is not normal. Okay, for all the normal patient, you never see this blast cell. When you see a blast cell, we always have to think there's something wrong with the marrow. Either this patient having a leukemia, or something is infiltrating the bone marrow and causing this abnormal cell called blast cell, which is leukemic cell. So shown here is one of the picture of the morphology of patient's bone marrow. You can see, this is not to teach how to see this leukemic cell, but you can see there's a lot of all these big round cells. These are what we call the leukemic cell. And this patient have acute myeloid leukemia, AML M4, and the FLT3 mutation we did was positive. The patient was treated with chemotherapy in combination with these FLT3 inhibitors, followed by a very good remission, and then followed by a stem cell transplant. And currently, post stem cell transplant, you can see that the white cell count is back to normal, and you don't see this abnormal monocytes count anymore. And this patient hemoglobin and platelet did not require any blood transfusion after the stem cell transplant, and he's doing well. So apart from this FLT3 inhibitors, we also have other targeted treatment in AML. It is difficult to go through all of this, but just an introduction that apart from this FLT3, we also have other antibody-based treatment. We have other generation of FLT3 inhibitors. We have another thing called this IDH inhibitors as well. And one of the medication we give for elderly AML, who we think that cannot tolerate in high-dose chemotherapy, we always combine with gentler medication called HDAC inhibitors in combination with this targeted treatment called BCL2 inhibitors. So that's an introduction for targeted treatment in AML. And you look at how about ALL or acute lymphoblastic leukemia. So just first as an introduction, we can see the survival. So before I proceed with this ALL for the adults, ALL for the pediatric population always do better. They are reaching a target of 80 to 90%. And if you see for adults, of course, we are improving over the years. And now about 50% survival rate for the past 2 years. If you look at on the right-hand side here, how all this genetic mutation affect the treatment outcome, you can see that not all patients need bone marrow transplant. those with a very good genetic mutation actually do not need transplant, and their survival is over 90%. Whereas on the lower curve here, we can see that this mutation called BCR-ABL, these are the mutation. The patient have this type of mutation, they will benefit from a targeted treatment as well as for bone marrow transplant. And what is this BCR-ABL? Usually, this is a genetic mutation found in the type of leukemia called chronic myelogenous leukemia or CML. This is a type of a low-grade kind of or slowly progressive kind of another type of leukemia. But at times, we also found that this patient having acute lymphoblastic lymphoma. And similarly, when we treat this patient CML with what we call tyrosine kinase inhibitors, we can also use this TKI, tyrosine kinase inhibitors, in the treatment armamentarium of acute lymphoblastic leukemia. And that's to treat the patient. So shown here is one of the patient of mine with the CML. Unfortunately, he progressed to this acute lymphoblastic crisis or ALL. And when we checked for the mutation, he was initially treated with the tyrosine kinase inhibitors, second line, second generation. 3 months later, his white cell count suddenly increased instead of remaining better. And we found out this patient actually have acute lymphoblastic leukemia. And shown here is one of the slides of marrow imprint on when we did the bone marrow for him. You can see a lot of this roundish cell. And just trust my word that these are all the leukemic cell or acute lymphoblastic leukemia cell. And this patient have this genetic mutation called T31K and T315I mutation. And these are the ones that actually confer a poorer outcome for the patient with CML and for ALL. And that's why they progress to become ALL. So of course, with this, you need to incorporate a third generation of TKI and with the combination of chemotherapy. So we actually treated him. He went into good remission for like a transplant, and he's still doing well currently. So what happens if patient is refractory or not responding to conventional chemotherapy, or relapse after the chemotherapy, or fail to achieve what we call the negative measurable residual disease? We can use a lot of antibody-based kind of treatment, as well as a new treatment called CAR T cells. So antibody-based kind of treatment, how does that work? So we know that all the surface of the tumor cell has certain biomarker. If you use this antibody, the green color here, it attach to all these antigen and cause the cell to die by different ways. Either the cell will actually incorporate this antibody, and this antibody, if you put toxin together with the antibody, the toxin will actually kill off this tumor cell. The other way how this antibody can work is that one side of this antibody will attach to the tumor cell. On the other end, they'll bring in or they'll attach to tumor, the army of our immune system, or called effector cell or the T cell. All these T cell actually kill off this tumor cell. And thirdly, you can see once they actually attach to the tumor cell, they can bring in all these, I call that biochemical changes in the body, we call complement, and this will kill off the cell directly, causing a lysis of the tumor cell. So shown here is one of the antibody we use in relapse refractory acute lymphoblastic leukemia, CD22 antibody. You can see here, this antibody is associated with a toxin. And when attached to the tumor cell, this antibody will engulf into the tumor cell, and then it will cause the toxicity to the tumor cell, and the tumor cell will die. And this actually improved the outcome for patients having a relapse disease or having a measurable residual disease, where you use this medication to get a deeper response before the patient go for bone marrow transplant. We have another antibody called bispecific antibody. It's almost like the idea you buy, you add on one. I think in this current COVID pandemic, most of us, if not all, we have this experience in buying something online. And if you buy one thing online, you always see that there's something complementary to make your buying experience or shopping experience more fulfilling or more exciting. You see, we want to buy a bike, then you have all these training wheels or something a lot to make the whole experience better. So if one antibody can work well, how about add on another one? So that's the idea of a bispecific antibody, two antibody in one. On one hand of this antibody, you bring in the army of the immune system to target the tumor cell. On the other hand, you actually direct the army to attack the tumor cell instead of other normal cell. So that's the idea of bispecific antibody. And this is very directed, and it's very specific, and it's very effective as well. So another type of how we enhance the immune system, what we call chimeric antigen T-cell receptor therapy, or CAR T-cell. So basically, we know that our immune system, we always believe our immune system can fight infection or all this tumor, but how to enhance on the efficacy of this immune system? So we actually harvest the patient's or our own this immune system called T-cell, and we actually purify all this T-cell, and we genetically engineer this CAR T-cell or modify this CAR T-cell so that they can recognize the tumor cell. And once we actually genetically modify them, we actually grow them, right? Once you grow them to a certain level, you infuse this genetically modified T-cell back to the patient, and all this genetically modified T-cell will be able to recognize the tumor cell and attack the tumor cell directly. And the efficacy is enhanced with this genetically modification. This is not talking about something like alien or in the future. This treatment is already available in certain countries. So that's about the leukemia and how we use different immunotherapy and targeted therapy in AML or ALL. And next we talk about the lymphoma. When we talk about lymphoma, we always need to say that we always have to divide the lymphoma into two main groups, mainly Hodgkin and non-Hodgkin lymphoma. And most commonly, of course, we've seen this non-Hodgkin lymphoma, but we always see Hodgkin lymphoma in adolescents and the young adults. So we talk about classical Hodgkin lymphoma first. This is the most common lymphoma among the adolescents. And the median age of onset, you can see they're very young, around teenager to about 30 years old. And interestingly, all these lymph nodes always start from the neck or jaw area, and then they spread downwards. So you can see a lymphoma, a Hodgkin lymphoma, usually they spread downwards, instead of suddenly they appear, over your inguinal area or inside the abdomen. No, usually they spread downwards. This is classical symptoms of how this Hodgkin lymphoma actually progress. And for treatment of classical Hodgkin lymphoma, usually chemotherapy is the first line, plus or minus or in combination with radiotherapy. And in some cases, we also use this antibody-based kind of treatment for classical Hodgkin lymphoma. This actually antibody is attached with some chemical which is toxic to the tumor cell. And when they attach the tumor cell engraft this toxin and they'll die. Okay. Usually, previously we used this antibody base for relapse disease or patient who did not respond to conventional chemotherapy. But now it's been used in combination with chemotherapy in advanced stage Hodgkin lymphoma, not for all this early stage, but only in advanced stage Hodgkin lymphoma. The other way, if you want to use this more gentle approach called a BVD, we can use a chemotherapy called escalator Birkhoff. The issue escalator Birkhoff, is effective, no doubt about it, but you always a bit fearful of the side effects, especially that some patients, when you take it, it may cause infertility in the long run. And especially we are seeing a young patient, teenager, adults, we also need to think for the future for this patient. And shown here is one of my experience with one of my patients who presented with advanced stage classical Hodgkin lymphoma. You can see at diagnosis, this disease is quite aggressive, involves the spleen. As I said before, the disease always spread from top to the bottom, so it already involved this abdominal area and some of the involvement into the marrow as well. So this patient was treated with antibody-based kind of treatment in combination with chemotherapy. After 2 cycles, you can see most of the disease has resolved. Only one particular area here, which is under the right axillary, which is not that great, but based on this antibody-based treatment, continue, and post cycle 4, you can see all this lesion has really resolved, and patient continue to receive his treatment. So checkpoint inhibitors, I think Dr. Chin talked about this before. So it's basically unleash the immune system to attack the tumor cell. So as compared to other solid cancer, we found that all these Hodgkin with Hodgkin lymphoma always have this typical recurrent genetic mutation, which increase this expression of PD-L1. And this mutation is always at this 9p24.1. And hence, this is why Hodgkin lymphoma is one of the blood cancer that actually very, very responsive to checkpoint inhibitors. So I have one patient with refractory Hodgkin lymphoma, which failed all lines of conventional chemotherapy, antibody-based, and then so we have no other options. we only have this checkpoint inhibitors to use at that time. And we use after 2 cycles, miraculously, actually, you see most of the lesion almost went into a complete remission. And actually, he completed the treatment for 1 year, and he remains well without any treatment. After 1 year, actually stopped because initially we thought to transplant. But he did so well that, with this checkpoint inhibitors, actually we decided not to proceed and just monitor after 1 year of treatment. So we talk about Hodgkin, then let's talk about non-Hodgkin lymphoma. So for non-Hodgkin lymphoma, I always like to talk about chronic lymphocytic leukemia. It's one of my most topic of interest because I went for almost a year of training in this CLL. So this is one of the oldest disease known, and the incidence is actually highest in the Western world. So in Singapore, annually we get about 20 to 30 new cases annually. And actually, this disease, actually, I like to talk a little bit about it because some of the treatment in CLL actually can be, that's how the idea of how to improve the treatment for other B-cell non-Hodgkin lymphoma. And this disease treatment has made significant improvement from conventional chemotherapy alone to chemotherapy-free treatment currently, and all the way to the possibility of eradication of this total eradication of the disease. And patients commonly present with incidental findings of high white cell count, mainly the lymphocyte count, sometimes with all these lymph nodes enlargement. And there are a lot of targeted treatment available in the chronic lymphocytic leukemia currently. And one of the most, one of those pioneer in targeted treatment for CLL is what we call Bruton kinase inhibitors. This is one of the key target in chronic lymphocytic leukemia. Other small, newer medication that we can use currently and available in Singapore is this BCL2 inhibitors. And this actually increase the cell death and actually cause the cell to die naturally. We have also other newer generation of antibody called type 2 antibody, which increase the efficacy of the treatment. We also have other other types of inhibitors called PI3K kinase, but must be in cooperation with the antibody, but less favorable and not available in Singapore yet because of the mainly side effects. So Bruton kinase inhibitors, how they act? Actually, most of the B cell will have this B cell receptors, and if you have mutation at this BTK, which is here, it's very targetable with this type Bruton kinase inhibitors. And Bruton actually is a name of a general who found that this deficiency mutation in a pediatric patient having a recurrent infection, and when they have this mutation, lack of this Bruton kinase, patient actually have the risk of getting a recurrent infection. And shown here is one of the elderly gentlemen I treated with this Bruton kinase inhibitors. You can see after the treatment, usually the white cell count will go out a little bit. Why? Because when you use this Bruton kinase inhibitors, all the lymphocyte cell, all the CLL cell, we actually immigrate from the lymph nodes, from the bone marrow into the peripheral blood, and they die naturally from that. So you can see a slightly raised white cell count first before they actually die from here. And this patient is quite a high risk because elderly definitely. He also have some bypass before for his underlying cardiovascular condition. But it is possible to treat elderly population. We never give up on the patient having this slow-growing cancer, which is CLL. And Bruton kinase inhibitors, as I said, is how actually CLL actually expand and learn about the disease progression for B cell actually is applicable for other conditions as well, such as Waldenstrom, mantle cell lymphoma, certain patient with diffuse large B-cell lymphoma, and with this double expressor we call. And certainly, it also effective in what we call that central nervous system diffuse large B-cell lymphoma. So this is how learning about one B-cell lymphoma can applicable, some of the treatments is applicable to treatment of other blood cancer. And BCL2 inhibitors is one of the excitement in treating CLL is a chemotherapy free. So basically when you target this BCL2, which is commonly found in patients with CLL, and this when you target this, the tumor cell will die. So one of the treatment approved currently is in combination of this BCL2 inhibitors with the antibody. And share here is one of the experience of my patient. Once you started the patient on this BCL2 inhibitors in combination with antibody, you can see that patient have a remarkable response and currently continue on treatment. So other type of antibody against lymphoma is what we call type 2 antibody, type 2 CD20 antibody. We also have all these new antibodies, CD79 antibodies, CD22 CD30, and of course, I talk about this bispecific 2-in-1 kind of antibody, and this is also some of the treatment available for lymphoma. And this is one of the patients when out of desperate situation, I use this bispecific antibody. It's a patient with a primary refractory diffuse large B-cell lymphoma, failed all conventional line of treatment incorporating newer target of antibody as well as the older type. And we have to use this bispecific antibody. And after one cycle, which is about 8 weeks, she went into a complete metabolic remission. So maintenance and monitoring, I got some question about maintenance. So the role of maintenance actually depends on the subtype of lymphoma, and it's more applicable in patient having a Hodgkin, certain types of relapse Hodgkin, as well as B-cell lymphoma. And the benefit is shown in the follicular lymphoma, certain type of non-Hodgkin, indolent non-Hodgkin lymphoma, and some elderly DLBCL. And for follicular and non in this anti-CD20 antibody, and usually based on the conventional published data, the maintenance is about 2 years only. There have been data showing whether there's any benefit 2 years versus 5 years, and there's not the data based on that is not shown, and hence usually we only use up to about 2 years. For CLL and Waldenstrom, the medication is called retreating the patient currently with protein kinase inhibitors, and these are the group of patients that you need to continue on the medication. So what from previous experience and from all this data, we know that once we stop the medication, the white cell count will slowly increase back, right? So hence, unless the patient can incorporate these protein kinase inhibitors with a newer type of antibody and can achieve a very, very deep remission, then we need to continue on this treatment. Unless the patient can have a very deep remission, then we have to do more study to understand how this patient will respond once we stop the medication. Of course, monitoring of the disease for lymphoma, you always use a CT scan or PET CT scan. Previously, in the era of without PET scan or newer recommendation, we always do the CT scan for patient every 3 months, 6 months. But now we know that the symptoms of patient is more important. That's how we monitor the patient currently after treatment for lymphoma. Of course, we can use other things like protein electrophoresis or etc. or full blood count to monitor the patient's disease. Other thing that newer technologies, what we call circulating tumor DNA, we can detect this circulating tumor DNA before the disease relapse. However, this is still experimental. Of course, it is available in certain countries, but we don't routinely use. Why? Because once you know when this patient going to relapse, it can be 1 year later, it can be a few months later, we do not know. So these are the period, whether patient will be in anxiety if we detect it. Of course, we can talk about, adding some antibody or what to maintain it until you have a better and newer data, right? I think this is something more of a research currently, but glad to know we do have this more technology to know. And how do we do that? It's just from the blood. So finally, it's talking about this multiple myeloma. So multiple myeloma in Singapore, the incidence is increasing. Why? Because we have an increasing aging population. And this is due to the complication or clinical presentation of multiple myeloma is due to the accumulation of abnormal protein in the blood. And this protein is produced by a cell called plasma cell, which become cancerous. And shown below here is historically how patients present with this multiple myeloma. You can see the normal bone with a lot of holes here being eaten away by the cancerous multiple myeloma cell, and patient always have a fracture here and there, and that's how we see all this abnormal finding of the bone. So on the left upper hand corner here, these are the normal plasma cell which produce few types of antibody. But if this plasma cell became abnormal, so they only produce one type of antibody alone. So this is abnormal. That's why all patients with multiple myeloma have the symptoms because of this accumulation of abnormal protein. And of course, we can use many blood tests to check it, but the one that can show about 90% sensitivity is what we call serum free light. So multiple myeloma patient always can present with a bone fracture, very high calcium, kidney failure, as well as the symptoms of anemia. And when we diagnose a patient with a multiple myeloma, we also look at the bone marrow, the percentage of plasma cell, more than 60%, or if got any bone fracture based on MRI, we'll start treating the patient with the treatment. So now, we always, for multiple myeloma patient, we always classify the patient into transplant eligible, or transplant ineligible. The idea here is for transplant eligible, we give the treatment and then consolidate, followed by an autologous stem cell transplant and maintain the disease in a very, very low tumor load with the medication. For transplant ineligible, we always give the medication, the treatment until the tumor load is very, very low, like here, to prevent all this relapse refractory disease. That's the idea. Give very effective treatment upfront, and we make the tumor load until very low, so the patient can remain in a longer remission. So shown here are the different types of classes of treatment available. Interestingly, most of them are targeted treatment or immune drugs. And in fact, only this chemotherapy, this is the only group of chemotherapy we use for treatment of multiple myeloma. And we are using it lesser and lesser nowadays, especially for transplant eligible patients. Of course, we also use things like steroids as a combination with all this targeted treatment. Other supportive care drugs also need to be used. Of course, we have to use patient have, as I shown before, the patient may have all this abnormal bone finding, and we always use this what they call that bisphosphonate to actually improve on the tumor microenvironment so that the cell can die and to strengthen the bone. We also need other things like all this antiviral medication, right? So on the left-hand side here is we've shown that there are increasing more and more newer targeted treatment available for multiple myeloma. On the right-hand side here, you can see with the increasing availability of this newer targeted treatment, and the survival of patients with multiple myeloma actually improved. And now the median survival improved from about 3 years to about 8 to 10 years. In the about 5 years survival rate in Singapore, we are talking about at least 50 to 60%. Of course, other genetic profile also affect the survival of multiple myeloma patients. So one of the classes is this proteasome inhibitors. What are these? We have all these things proteasome. What is this proteasome? Basically, almost like a garbage bin in our cell, in the cell. So if you this garbage bin is important because some of this abnormal protein or useless protein will be degenerated, will be recycled here in this garbage bin. So if this proteasome inhibitors works by actually inhibiting or make this garbage bin dysfunctional. So if this garbage bin is dysfunctional, what happens is, of course, the cell will accumulate more and more abnormal protein in the cell. Eventually, they will die. So that's the idea of these proteasome inhibitors. And this is one of the things that actually change how we actually treat multiple myeloma patients. And it is one of the backbone for treatment of multiple myeloma. You can see there are many different types of these proteasome inhibitors available currently. Now, for antibody-based kind of treatment for multiple myeloma, one of the things is we target, as I said, I showed before, we have a lot of antibody-based treatment for the treatment of blood cancer. And one of it is this, what we call CD22 antibody. And you can see here how they attach to this multiple myeloma cell and how they actually cause the cell to die or improve or increase bring in the, what do you call that, immune system to target this multiple myeloma cell. This antibody-based treatment for multiple myeloma. Another things we have a class of medication we have for the treatment is what we call immune-modifying drugs. We call IMiDs. This treatment actually is one of the important backbone as well. They actually increase the cell death, right? At the same time, they also bring in the immune system to actually target or kill this multiple myeloma cell. This is a class called IMiDs. So there's so many choices of combination. If I show you many different classes, and this, to make things a little bit more complicated, we always combine 1 + 1 = 3 kind of thing. So we have a lot of treatment available. We always divide into transplant eligible and non-transplant eligible. And I think we always want to give the best treatment. And one of that, my favorite is using this thing called VRD or bortezomib, lenalidomide, and dexa, which can increase the response about 97%. And what happens if the patient have relapse disease? I said before, we always have this bispecific antibody. And the same thing, if we can bring in the army, we just have to think of a target to direct this tumor cell. And this is what we call BCMA. BCMA is present in most of these multiple myeloma cell. If you can direct the immune system to target this BCMA cell, and all these myeloma cell will die. And this is what I call different design of this bispecific antibody. Finally, we also have a CAR T cell for multiple myeloma. It's the same thing, same kind of concept for CAR T cell, but the target is a bit different. we use this BCMA as a target. So the bioengineer, the antibody or the receptor is this BCMA to target specifically for all these multiple myeloma cell. So these are the many treatment and design available we have for the treatment for blood cancer and especially for multiple myeloma. So in summary, so blood cancer actually can be divided into leukemia, lymphoma, and myeloma, just to emphasize on this. And there are many different new target and immunotherapy available for different types of blood cancer currently. And I just share with you some of the different types and few of those which are available in Singapore. So now, similar to how oncology treat their patient, we always want to understand the genetic changes and pathology of disease, so we can tailor the treatment or personalize the treatment for all the patient and not like one size fits all kind of approach. And with that, I'll end my talk. And this is the final polling question to see whether my presentation actually makes an impression of the different types of treatment or targeted treatment available in Singapore. Oh, okay. Well, at least most of us are aware that yes, all these treatments are still available and are available in Singapore currently. Okay, with that, I would like to stop my talk, and then we go to the Q&A session. So, it's back to you.
Okay.
Thank you, Dr. Chin and Dr. Lee, for both your sharing. We apologize that we have overrun the session for about 10 minutes, so we'll keep our question and answer session a little shorter. So perhaps 5 questions each for Dr. Chin and Dr. Lee. Over to you, Dr. Chin.
Okay, so I've scrolled through the questions, and I think I'll group them into 3 major questions so that we try to finish in 5 minutes. So there were quite a few questions about, non-smoking lung cancers. So we spoke about how smoking is definitely a risk factor for lung cancer, but it is true that over the years of my practice, we do see quite a lot of women who are never smokers, not even passive smokers from work or from home, who have been diagnosed with lung cancer. We, for some time, have been trying to look for the reason, and at one point we were thinking perhaps these Asian women are cooking in the kitchen and they're exposed to a lot of cooking fumes, and that may potentially be a source of cancer-causing carcinogen. There have been big trials that have been done, but unfortunately, the link between cooking over the stove, fumes, has not actually borne out like smoking has. The other thing I think to be aware about is sometimes they may think that they don't smoke, but they are exposed to smoke in their workplace or at home. So this is what we call a second-hand smoking. Sometimes there is also third-hand smoking, where you walk into a room and because somebody has been smoking, it's on the furniture, it's on the clothes, etc. But for sure, I think that there are women, men who don't smoke, who do come down with lung cancer. The good thing is that I think for this group of patients, we have also found that in the non-smoking population with lung cancer, there tends to be a higher incidence and percentage of patients who may be more suited for targeted treatment, meaning that when we look at their cancers, they have specific genes that we spoke about, and we can target them with medications. And along the same lines of targeted treatment, somebody asked a question about how do you profile the molecular signature. So most of the time, we confirm the diagnosis of cancer with a biopsy. And if there is sufficient tissue in the tumor, we usually prefer to look in the tumor to see what is the molecular signature and makeup. But sometimes due to insufficient tissue, we may also look at the blood, what we call liquid biopsy, meaning that we draw a blood sample from the patient and we try to look for these mutations that we would usually look for in the tumor in the blood instead. And it has proven to be quite a good biomarker as well for some patients. So we can do it on the tumor, potentially we can do it on the blood. Then there are some questions about screening for lung cancer. So I think the message that early stage lung cancers do better than more advanced stage, and the public has rightly asked. So can we try to pick up lung cancers earlier? Is there anything that we can do to screen? Chest X-rays, so the routine, just a one film X-ray, unfortunately has not borne out in terms of cutting down on death rates from lung cancer. But we do know that if you smoke a lot, for example, if you smoke for 30 years and you smoke a pack a day, so what we call 30 pack years, you may want to consider doing low dose CT scan because that may pick up lung and potentially if early stage, then we can try to resect and the outcome may be better. So I think that would be my section, and the rest I will try to answer directly on the chat group.
Okay, Dr. Keen, thank you very much. I'll hand over the session to Dr. Lee.
Hi, okay. Now I got one of the, probably interesting question about this rituximab. Okay, so one of this question is that what's the role of giving rituximab during COVID time? Will that increase the risk of getting infection? I guess it's a bit difficult. I guess it's the rituximab now depends on whether you need it for the treatment of your current disease. If you have active lymphoma currently, you should continue on the treatment. In fact, what's the interesting thing that they found out about this targeted treatment using protein kinase inhibitors. In fact, based on one the article they published, it seems that this BTK inhibitors actually improve the or reduce the mortality of the patient within having this COVID time. So with that, most of the patient having targeted treatment will continue unless you have evidence to show that it shouldn't be. And one of the things that may happen if you have a patient on rituximab, sometimes you do find that after the completion of rituximab, like 6 cycles, the patient have a delay onset of neutropenia, what you call that low white cell count. It is, based on experience, every year when I treat patients with this non-Hodgkin lymphoma using the rituximab, you're bound to see 1 or 2 patients having this delayed onset of neutropenia or low white cell count. And this is related to, some of it may be related to a genetic effect. Some of it is what we call bystander side effects from the normal white cell count. And most of the time, this patient, you need to exclude whether this patient has active disease or any active infection. Once these are ruled out, and this is a diagnosis of exclusion, and what we can do is actually we can stop this rituximab and let the white cell count recovers. What's interesting is most of the time, this patient do not need any maintenance. This is very specific, and they do quite well. My experience, a few of them patients, they actually do quite well even without maintenance, and the disease after 5 or 6 years never come back. Okay, and we also have a question regarding the tumor size after the chemo and radiation for non-Hodgkin lymphoma. So usually what we do is now currently we are using the PET CT scan. If the PET CT scan show that there's no patient have there's no evidence of disease, or we call level 1 or level 2, based on the PET CT scan, we are okay to leave it. And most of the time these are the scar, and it may go away with time. Sometimes they will be just leave a very minimal scar. Of course, you need to follow up closely with your physician to monitor for this. And most of the time, they'll just rescan again if they're not sure, or they may just follow up symptomatically based on the patient's symptoms. And MRD test for minimal residual disease for lymphoma, I said before, we can use this thing, a newer technology called circulating tumor DNA. It is not available in Singapore, but it's available over the other country we can send over. Of course, for my really pet topic is chronic lymphocytic leukemia or Waldenstrom models, we can measure the minimal residue or measurable residue disease using a technology called flow cytometry, and we can do that just by taking the blood and checking for all this what do you call that, measurable residual disease. Okay, what else do I have? Multiple myeloma after stem cell transplant, the survival rate. Okay, now this is depends on the depth of the response before the stem cell transplant and also the genetic profile of the patient at presentation. And it's not an easy question, and you have to see the fitness of the patient. All these actually affect the survival rate for all these patients with the post autologous stem cell transplant. And regarding the maintenance therapy used for multiple myeloma after the stem cell transplant, and we always recommend continues on this treatment based on data. There's the previous experience, we always stop after a while. But the newer data and the current recommendation, if you have multiple myeloma, you maintain it. Usually, you can control the disease longer, and that will improve the survival. I guess that will be all for. Okay, one last question is blood cancer hereditary? So now it is there's some genetic predisposition, but it's actually not directly hereditary. As in, from one patient you don't, from one parents you don't pass it directly. There's some linkage, certainly some risk of increase blood cancer, but it's not directly applicable. Like one patient have a lymphoma, that your children will have lymphoma. No. Okay, I think with that I finished my Q&A session. And thank you very much. Thanks again for all the attention and for participating in our talk today.
Thank you, Dr. Lee. And thank you, Dr. Chin, as well, for both your presentations and for addressing all the questions. We apologize that we're unable to address all the questions, and we sincerely thank you for your attention and for inputting all the questions in. But if we haven't addressed your questions and you would still like to seek the doctor's comment, feel free to reach out to the doctors at their email, which is listed in the screen now, on the screen now. Or you may choose to scan the QR code to download their contacts into your phone. So I would also like to take the opportunity to invite you for one of our upcoming webinar, which is happening next Saturday on the 1st of August at 2 p.m., where our medical director, Dr. Ang Ping Tiam, and Dr. Colin Phipps-Tiong will be sharing more on cancer recurrence. So this event is jointly organized with Channel News Asia. To register, you can scan the QR code or go to the URL https://meevents.sg. So I think with that, we don't want to hold you up from your lunch. Thank you very much for your time. Thank you, Dr. Chin and Dr. Lee, for your time and your sharing as well.
Thank you very much.
Thank you. Stay safe.
All right. Thank you, everyone, wherever you're tuning in from. So upon closing the webinar window, you'll be prompted to do a short survey. Do let us know how we did, and we would love to hear your comments on how to improve our future webinars. Thank you once again. We hope to see you very soon. Goodbye.
Bye. Can leave right here.
To correct.